Good morning. Thank you for attending. My name is Melissa Uy. I'm from NUH. And it's great to see the people in the audience after so long. And forgive me if I'm nervous because I haven't spoken to a live audience for quite some time. It's all been through Zoom and you just look at a computer screen. So I would like to talk a little bit differently from what Dr. Mauli had spoken about. I think he's given us a very great overview of what new treatments we have available. But I think that we do see a lot of more elderly patients in myeloma, and I think that the focus of my talk will be more on this particular group of patients. And if you are in that group of patients, or if you are a caregiver for one of these group of patients, I hope that this talk will be useful to you. So these are my disclosures. So I think that it's no surprise that we do know that as we age, there is more patients with cancer. I think we see that across, kind of all different types of cancers in not just Asia, Singapore, but around the world as well. And certainly, myeloma, as you know, does increase with age. So people who are more elderly, have myeloma as opposed to a younger cohort. So unfortunately, as we age, we also know that our body starts to break down. We're not as robust, we're not as fit as when we were younger. So our organs, start to go a little bit, go downhill a bit. We are not as fit. Our heart may not be so good. Our lungs may not be so good. So these are all things that we would need to be able to fight cancer. Yet at the same time, as we age, our reserves go down. So what do we do? How do we help patients? So I think that some of the challenges that an older cancer patient may face is comorbidities. What do I mean by that? I think as Dr. Mauli said, most patients may have other conditions like diabetes, high blood pressure, cholesterol. I think that's kind of the major big three that we always tend to hear people saying that they have. They may have other types of cancers. They may have lung or heart problems. So these are all things that we would need to take into account when we are thinking about how or what treatment we want to give to someone. As I mentioned, sometimes they don't only have one cancer, but they may have another cancer in the past, or they may currently be battling a cancer when they get diagnosed with myeloma. So again, this would be something that we would need to think about or take into consideration as well. And we do have age-associated problems, arthritis, back pain. That's not related to myeloma, but again, when we are thinking about treatment, these are things that we would need to think about. So I think that when you get diagnosed with cancer, I know it's a shock, and usually that's the first thing, like, oh my God, I have cancer, what do I do now? But don't be afraid of your doctor. We are here to help you. We're not scary. When you sit with us in the clinic, the first thing you need to tell is, what are your treatment options? Don't be afraid to ask. If you're not sure, just please ask, because sometimes we might talk very scientifically, we might give you a lot of options, and it might seem very daunting, very scary, but I think if you just say, hey, stop, can you just tell me that again? Most of us, will be more than happy to do so. And, we can talk through one by one what is suitable for you. We also want you to stay safe. We want you to stay independent while you're undergoing treatment. And especially in COVID times, definitely staying safe is very important. So again, there might be some tips that we would give you on how to do so. And the most important thing, I think that sometimes we don't have enough time to address in clinic is your emotional health. We do know that this is a very, a diagnosis that definitely affects you, not only you, but your caregivers as well. So again, your emotional health is very important. If you're suffering from some stress, or your caregiver is suffering from some stress, this is something that you can let us know, and as much as we can, we will try to help out with that as well. So I think that this is sort of for the new patients, and even for those who may have undergone a relapse and hearing about it for the first time, things that run through your head are, what are my treatment options? What are the side effects that I might have? Can I talk to you about, the outcomes that I want? What is important to me? And people always ask, what is the stage of cancer? How was it diagnosed? Is it genetic? Can my kids get it? So these are all things that you can talk to your doctor about. You don't have to do it all in one go. You can piece it out as you're meeting him or her or over the course of your treatment. So always, take into consideration, your type of cancer, its stage, what treatment options you have, what are the risks and benefits of each option, and how the treatment itself may impact you as the patient. Again, it goes back to what you have originally. Does it impact your physical health, your emotional health, your type of lifestyle? If you were previously someone who travels a lot, you may not want to have injections. If you were scared of needles, that may be something that you might need to tell your doctor as well. And also your personal situation. What is important to you as the patient? What kind of social supports that you have? Do you have, if you're lucky enough to have, children, a wife, a helper, the whole sort of village that can help bring you, or maybe your children are overseas, you have lesser social support. Again, these are things that you need to let us know, and we will consider all this, before we start some treatment for you. And obviously, as always, financial is something that in Singapore, it is something that we always need to think about as well. And again, if finances are a concern, do let us know. We do have means and ways to help. And I think most of us know that in September, there will be some changes. So if you are struggling, especially with come September, do let us know prior to that so we can, again, think about what is the best treatment option for you. So I think the goals of any cancer patient, any myeloma patient, is to get the cancer under control. As Dr. Molly said, we can't say cure right now, but at least we can control so you can get on with your life. We hope that you will live longer with treatment, and we have multiple lines of treatment now that can do that. We also want you to have minimal symptoms. We don't want you to have a lot of side effects. So if you have side effects, let us know, because again, these are something that we can manage and we can do, but we don't want you to, it's no point curing you only to not be able to get out of bed because of too much fatigue, or you have too much side effects from the treatment, such as numbness, and then you can't do your normal things that you want to do. We also want you to maintain your health and your independence, get about, do your daily life, go back to work if you're working, etc. And I think the most important is that we want you to have a good quality of life as you're undergoing treatment. We don't want you to have to suffer from any of the side effects from the treatment itself. And if you do, please let us know, so at least that's something that we can help address. So when you see the doctor, there's always a lot of treatments that they talk about. We can go for this, these are the side effects, we can go for that, these are the side effects. So again, talk to your doctor, talk to them about what is important to you, and between between you, your doctor, and your caregiver, you guys can come up with a treatment that suits you. So some of the side effects that most people are most worried about is, for example, if you're undergoing chemotherapy, you might suffer from things like, in myeloma, you don't get hair loss, which is something usually a lot of people ask. You don't actually get hair loss with most of the myeloma treatments unless you're going for transplant, but you will get fatigue. You might definitely have risk of infections. Especially in the beginning, you might need blood transfusions because your blood counts may go down. You might suffer from diarrhea or constipation. You may suffer from shortness of breath. So these are all things that I think that each treatment will have their own side effects, and it's quite important to understand them. Certain side effects we can help with. Certain side effects might necessitate us to reduce your treatment dose. So again, if you don't tell us, then we won't know, and we think everything's going fine, and we just keep pushing on, and then you're there suffering in silence. So please don't do that. We may also advocate some radiation. I don't know if anyone's had it before, either here or at home, but sometimes if you have some spine disease or a specific area, we might say, hey, let's go see our radiation oncologist. They can just help zap that area and sort that problem out quickly for us. So again, radiation does have their own side effects. Depending on which area the radiation is happening, you might suffer from some skin irritation. If it's more towards the gut, you might have diarrhea. If it's the back, sometimes you might suffer from some organs that might be affected by the radiation itself. So again, all these are side effects that you can ask your doctor about. Don't be afraid to ask them. There are also some supportive care medicines that we tend to give. I think most of you may on it. Bone strengthener, because as Dr. Mali said, myeloma does affect the bones. So we want to give things like calcium, vitamin D, to make sure the bones stay strong and healthy. And we give some either the Zometa or denosumab, which is a medicine itself for bone strengthener to prevent fractures in the future. We also usually give a lot of antimicrobials like acyclovir or Bactrim or some sort of antibiotics to prevent infections as you're going through treatment, because as I mentioned, when you're on treatment, your immune system does go down a little bit, and we don't want you to get like a bad infection. So in NUH, we have this service called Golden. It's actually a geriatric oncology service to care for older adults with cancer. And I'm privileged to be part of this group. We have, it's a multidisciplinary team comprising of nursing, allied health, physicians, and those who are familiar with your NUH colors, you can tell the physiotherapist, the doctor, and the nurse in the group. We also have, our allied, our nurse practitioner, I think Chiching, some of you may be familiar with her. And together, we are part of this group to try and understand and help our older cancer patients. So we do something called a CGA, or a comprehensive geriatric assessment, where we look at things like the activity level of the patient, other medical conditions that they may have, some memory problems, what their nutrition is like, their emotional health, their social support, what medications they're currently on. This is all we do before we actually start someone on treatment, just to understand at baseline what is their condition. And then between sort of the geriatric assessment and talking to the patient, we would like to hear from the patient itself and from the caregivers what their preferences are, what their expectations, and this will be communicated to the patient and the caregiver to understand what they want, so that we can together come up with a treatment that is acceptable to all parties. So certain issues that we see more in the older patients compared to younger is that they have more functional limitations. They may not be able to walk as much, maybe because of previous arthritis, or they may have, as I mentioned, back fractures already from the myeloma, so they may have some limitations in that. Those who already had treatment before for myeloma or from other things may have some complications from their previous treatment, which we need to take into account. Fatigue is a real problem, not just from the treatment, but the cancer itself can give you fatigue. There's also some issue with cancer causing some memory problems. I think sometimes you might find you have something called a chemo brain, especially when you're on treatment. You might find that you're more forgetful, and this is a real thing. You're not, if someone says that, you say, oh, it's because of my chemo, and they say, you're making it up. No, it's true. There is something called chemo brain. You actually do get more forgetful as you're on treatment, and we do recognize that, and that is a problem. There are specific side effects from your cancer treatment that may increase your risk of falls, for example, if you get like numbness in your hands, or you might be unsteady on your feet. And there's also bone health issues. From a lot of steroid use, you can get side effects such as osteoporosis. From the myeloma itself, we can also get osteoporosis, so from both cancer and treatment. So I think that our strategies to improve QL is quality of life for our cancer patients would be to, first of all, identify them by doing the CGA and evaluate them. Then, as Dr. Mully said, we do advocate for exercise, because our exercise can help with some of the treatment-related complications, as well as the fatigue that you might find in the treatment itself. And I'll show you a slide later on that shows that exercise actually does, even a little bit, does help with your general health. Then, we have to take care of the other parts of your body that, may be related or may be affected by myeloma, like your bones, and also your other medical problems, because you're not just a myeloma patient. You are Mr. Tan or Mrs. Lim, with all your other sort of hypertension, heart problems, and everything as well. So again, we're not just looking at you as a myeloma patient, we're looking at you as a Mrs. Tan or Mrs. Lim, as a patient as a whole. So this is the CGA. It looks very like a lot of words, but don't worry. So essentially, these are all the various things that we look at when we are doing the geriatric assessment. As I mentioned, you look at nutrition, look, how is your diet? Have you lost weight? We look at your functional status. We look at how your hearing, your vision is, because again, this may increase your risk of falls. If you have bad vision, if your hearing is not good, you may not be able to hear very well what the discussion is about. Medications is very important. I'll get to that in a little bit. What you are taking before we started the treatment. Again, cognition, your brain, very important. So your memory, how is it? Especially if you're alone, this is very important because you're taking care of yourself. Then how are you emotionally? How affected are you? And I think our social worker will go through in a little bit detail of how you can help with some strategies to help with that. What social support you have, and what is your caregiver status. And I think that who carries out, as you can see, it's a real multidisciplinary team. So we have all these people in our team that will help us look into the various aspects of the CGA and to help out if we find that maybe this person or that person has one or two problems in that area. So then we would refer them to see the physio or the MSW, the social worker, or maybe sometimes even the psychiatrist to help if they have really a lot of effective problems. And as I mentioned, why exercise is important. We do see falls in quite a lot of older cancer patients. That is one of the questions that we ask. How many falls have you had in the last year? Because we do know that about 30% of cancer patients do fall, whether it's from some dizziness or whether it's from a mechanical issue. As you get older, your falls risk does increase to about 50% after you get to more than 80 years old. And when you fall, you may develop injuries, especially if you're on treatment, your blood count is low, you might get a very big hematoma, like a blood or a big bruise as well. So how do you decrease your risk of falls? One of them is by actually doing exercise, so you improve your muscle strength. Environmental, so again, we need to make sure that, for example, the toilets, there is grab bars installed, that if it's too low, you might use a commode rather than, use a normal toilet. You might have, if you have a step, then we would maybe suggest a ramp. So these are all things that our physio, our OT, when they are assessing you, can also, get a layout of your house and see how safe it is when you're at home. Again, if you have vision problems like cataracts, for example, from a lot of steroid use, we might say, they'll refer you to the ophthalmologist to get the cataracts sorted out. If you're on certain meds like sleeping tablets, etc., we may, decide to change certain medicines to improve your, like if you're having a lot of side effects or the sleepiness as a result of some of your medications. So, as I mentioned before, and I'll mention it again, exercise. I think those who see me in clinic will know I'm always asking you how much exercise have you done? So it does help, even a little bit. It does improve in your bone health, it reduces your fatigue, and as Dr. Molly mentioned, it does prolong survival, so it is quite important. Do as much as you can when you can. So this is all not just some voodoo science that we came up with here. This is actually based on a study that was done in 2015 in Italy, where they looked at about 1,000 over myeloma patients in clinical trials. So these are like the most cherry-picked patients. And they looked at a couple of things, what we call ADLs. So what is ADLs? Activities of daily living. So I think that most of us who are trying to fill up social support forms, MSW forms, will know that they comprise of your bathing, dressing. Toileting means being able to go to toilet yourself. Transferring, that means moving from bed to chair or chair to stand. Continence, and feeding. So these are the main basic things that, if you can do them, that's good. If you can't, then it shows quite a bit of deficiencies already. IADLs are things that are a little bit more higher order thinking. So ability to use the telephone, ability to go shopping, to buy things, making sure you get the right change, remembering your list, your shopping list, food preparation, housekeeping, doing laundry, transportation, taking the MRT by yourself versus if you have to have someone accompanying you, being responsible for your own medications. So these are things that, again, we would do in our geriatric assessment, and it's been done in this study. So they looked at these few things, and then they calculated based on the patient's medical history as well. And they actually found that, a bit small, but they found that there is 3 groups of patients: a fit group of patients, an intermediate group of patients, and a frail group of patients. And as you can see, the patients actually do stratify quite well. So if you are fit, you tend to have a better outcome. So your what we call progression-free survival, or your overall survival is longer. You tend to have also less problems with the treatment itself. So you can see from this graph here that patients who are fit, 84 versus 57 who are frail, will tend to have a better overall survival. Whereas patients, and in terms of side effects, if you are fit, you tend to have less side effects versus if you were frail. And you're also likely to continue on treatment if you're fit versus if you're frail. So if you're frail, you might have more side effects, you might be less likely to continue on treatment, most likely because of the side effects, and overall, because of that, you do worse. So I think that it's quite important to find the fit the treatment to the patient, rather than trying to just give everybody a standard, kind of treatment A, treatment B, treatment C kind of recipe. So I think, for example, I'll just bring a case, a patient of mine. She's 79 years old. She has diabetes, hypertension, osteoporosis. She presented with tiredness for about a month, and she had back pain for about 3 months, which is quite typical for a myeloma patient. She went to the emergency, and she was noted to have like low blood count. So she was anemic, she had low platelets, she had low white cell counts. She was admitted, and then she was found out to have myeloma. And after discussing with the patient and family, I think the first question they always ask is, must I get chemotherapy? What are my treatment options? And I think that these are, remembering back on the shared decision making with the patient, I think it's quite important at this point in time to address her concerns and her fears. Is there something she's particularly worried about? What are her expectations? What are her own personal preferences for treatment? So, for example, if you recommend VRD, which is quite a common regimen, I think most of you may have had it or may be on it right now, Velcade, lenalidomide, and dexamethasone. Some of the side effects that one might suffer from is fever, nausea, loss of appetite, numbness from the bortezomib, maybe some blood clots, and you may get admitted for your fever. You may need to go for antibiotics, and you may need blood transfusion. So, I'm not going to make people show hands how many of these side effects that they may have had whilst on this treatment, but I think most people would check 1 or 2 at least. So, so these are most of the fears that patients have, and I think that it would be something that we would need to discuss upfront. So at least it's not scary. It's not something that they didn't expect. At least if you have the expectation, it's not so scary. And the pill burden is something that I would to mention. I think that I mentioned in the CGA that we look at what pills, what medicines you're on. But when we start chemotherapy, I do apologize, but when we start chemotherapy, we add more pills rather than we actually subtract. So we add the treatment pills, which is steroid, 5 tablets, lenalidomide, 1 tablet, bortezomib, which is an injection. Then we add in our supportive medicines. We give calcium, we give vitamin D, which is again 1 or 2 tablets. We give cyclovir, which is 4 tablets because it's 2 times twice a day. We give Bactrim, which is a very large horse pill. It's 2 tablets 3 times a week. We give entecavir if you have hepatitis B. We give aspirin. So I don't want to count, but there's a lot of tablets already. And lastly, you may be on all your regular medicines, right? Cholesterol medicine, blood pressure medicine, and other medicines that you are taking. So I think it's quite important that sometimes when we see patients, we end up giving, you feel like you're drowning in the sea of pills. And I do apologize for that. And that's why I think it's important that we address what medicines you're already on at the beginning, so that if you're on stuff that may not be necessary, at least we can try to reduce your pill burden by stopping some of them upfront. Because we know we're going to add on like another 10 more. So, we are subtracting maybe 2 and we're adding 10, but it's something. So again, apologize in advance, but there's no way around it. So just going back to the CGA, this is how the form eventually looks like. We look at all the various domains, and then we highlight the things that are important. And for example, for Mrs. T, we found that she was actually quite independent, able to do her own toileting, go marketing, etc. So she scored really well for what we call the CATS, which is the ADL, and the Lawton, which is the IADL. So there was no problem there. But she did have a fall, and her what we call time up and go. So we just get you to stand from sitting and walk for about 500 meters. And we time you how long you take to do that. And if you take more than 12 seconds, that shows us that maybe there is some physical decline. There's also some social activity interference. I think we see that a lot, especially post-COVID. People are not going out, they're not interacting with their friends. And it does have an impact on your life. They're not going down to drink kopi anymore, that kind of thing. And again, medication. So she was already on 6 prior to starting treatment, and then we're going to add another 10 more. So I think it's important that if we can, to try and reduce whatever burden that she may have before we add our own treatment pills to her treatment. So these are the things that, after the CGA, we actually discussed all the cases in a multidisciplinary meeting, and then we came up with the recommendations to stop unnecessary medication and to consider bone health medications. And at that time, she was having some issues with urine problems, so we recommended that she get it reviewed by the medical team to check some electrolytes. She was still inpatient at that time. And then to allow passive exercises, and she was on diapers, and to sort of review why, because obviously if you're on diapers, it does affect your quality of life. And there may be no need to be on diapers, but sometimes it's, when they're inpatient, you might find that they get put on diapers for no good reason. So in conclusion, I think that unfortunately, older adults, which is the majority of our myeloma patients, do face more challenges, but it is something that we can overcome. And I would like to, with patient advocacy here as well, to take charge of your own health and understand your medical condition. That's the first step towards, kind of getting better. To discuss with your doctor your treatment goals. Let us know upfront what is important to you, what you want as a patient. And for some people, a geriatric oncology service can help. As I said, as part and parcel of what we do, we try to understand your overall health and to get an understanding of you as a patient. And again, exercise. Sorry, I have to say that again. Staying active and exercising is actually crucial as part of your journey in your treatment journey. So you can do it. Thank you.